like yelling, fighting, screaming, things going on, pretty norm now. So you just might want to mute it until you have a question for Dr. K. So yes, thank you for being here. This is being recorded, so I hope you're okay with that, just to give the information to others. Hey, Mike. Yeah, any questions before we get started about logistic things? Okay, so yes, Dr. K is here with us. I think we all know who he is. We're very excited to have him. He's gonna do kind of, hey guys, hey Ethan. I was saying before, it might be helpful to mute your audio until you have a question, just so everyone else doesn't pick up the background noise. And then just unmute it when you have a question. Okay, so we're really excited to talk with Dr. K today. He's going to do kind of a brief presentation for us about COVID-19 and what he knows, what they know. And then we can open it up for questions and comments, concerns, discussion, whatever it is. So, Dr. K. Oh, you have to unmute, Dr. K.
Yep. Yeah, yep. I will try to share my screen, see if it's worked on other talks. So tell me if everybody is able to see it. Everybody can still see it?
Yes, we can see it.
Okay. So what we know, I have to say, in the field of medicine and science, I can't believe the speed of information and the amount that we as healthcare providers are seeing. There's been some unfortunate racist ideas about China and the Chinese, which I think are unfounded. Yes, we know the virus started in Hunan in China, but the ability of the Chinese to identify this, share it with the international community, the details, they very quickly were able to what we call sequence the genome, identify what it was, and share it internationally so that scientists and physicians across the country could very, very rapidly develop ideas. And the Chinese have been sending us lots and lots of case series of what happened with their patients when they were admitted to China. So I would say we in the as physicians in the world scientific community are very grateful for their transparency. I don't know if the data on the number of people infected in China is accurate. Has the national government squashed and not agreed to test that? We don't know, but early on, from January through early March, the amount of information that they shared with us constantly has been incredibly useful for us to plan and treat. And then, unfortunately, we learned some hard lessons from Italy, a first world nation who really wasn't prepared, and now from the US. So I want to share what we know. See if it's okay. So in any talks that I give as one of the faculty of the School of Medicine and a state of Colorado employee, we need to discuss if we have any financial disclosures with the industry, and I have none. But I also want to disclose that I am not an infectious disease expert, nor am I a pulmonary critical care physician who has cared for any patients with COVID-19 yet. So to date, everything I'm summarizing, I've learned from the massive amounts of data that's been shared amongst the physicians, both at the School of Medicine and just internationally. So this is a little bit outdated, and I'll go through some more updated slides further on in my talk. But as of when I gave this talk a week ago, there was 900,000 COVID patients worldwide. We know that's closer to, I think, 1.2 million. And I'll show that a little bit later. One of the most useful maps that you've seen on CNN, the local news, and everybody is through Johns Hopkins, where anybody can go to that map and look at details of prevalence of reported cases of the virus to date. Now, I want to emphasize this is reported cases. As all of you probably know, our ability to test is significantly hampered by number of tests available, and hence the true prevalence of the virus in all of our communities and across the world is probably a lot higher than what we've been reporting. And this is an important thing to keep in mind when I talk about the death rates and how this is affecting people, because we assume the prevalence is anywhere from 5 to 10 times higher than what is reported, because many of those patients that get minor infections, that they stay at home or just don't need to come to the hospital, are going unreported. Other important websites that I think are important would be the COVID-19 health data from the state of Colorado. And this gives you update day-to-day prevalence of identified cases in Colorado, which counties they're in, as well as the death rate. So a very interesting model from the School of the Information Health Medical Evaluation website from Seattle did, from the School of Public Health in Washington, predicted in different cities when the peak would occur based on data that they had from China, Italy, and the United States up to that point, and created models of when we were going to expect the peak to occur and what would be the estimated shortage of beds to care for all the people with COVID, both regular hospital beds and ICU beds. So they predicted, based on timing of when we started to socially isolate, that Colorado's peak was going to be around April 17th. The good news is from the last 3 days, it looks like that peak may have already maybe shortened to sometime this week, as the amount of people admitted to our, at least Denver hospitals, is starting to plateau. So that may be a little bit earlier, but it's still too early to tell. It was estimated that we're going to have 3,700 beds short to care for all the people that needed hospitalization, and short of 750 ICU beds. Now, these are beds that were standard number of beds in hospitals. What all the hospitals like University of Colorado Hospital and Children's have done is they've converted a lot of their other areas to more hospital beds and ICU beds. An example, we're not doing elective surgeries or procedures such as catheterizations. So OR rooms and the pre-anesthesia care units have been converted into possible ICU beds. So we think, based on all these preparations, that Colorado will have adequate ICU beds, ventilators, based on these changes. So that's some good news. What's some information? So looking at the popular news, CNN in particular, but also the local news, I think there's been some misinformation still, as any news outlet has its inherent bias. And even though I'm a big fan of the New York Times, I think it's a great source of data, it is clearly biased against our current sitting president. And hence, the way the stories are run show those inherent biases. You know, as a physician, as a scientist, I try to stay with what the truth is. So here are some truths that we know based on studies. So we know that the virus can remain stable in the air when it's aerosolized from a person who's got infected with this for up to 3 hours, maybe a little bit longer. And they don't necessarily need to be coughing. This could be just routine breathing, hence the need for the social distancing. We do know that also the virus remains stable for up to 24 hours on cardboard and likely paper surfaces, and about 3 days on plastic and stainless steel. So this is particularly pertinent when we all need to go to the grocery store still to replenish stocks and think about how long those could be contaminated when we're bringing them into our house, and need for either cleaning them or leaving non-perishables in a garage, let's say, for up to 1 to 3 days to make sure that they're no longer could infect us. The median incubation time, that means from the time you're exposed or inhale the virus to the time that you have symptoms, on average is about 4 to 5 days. That's what's making this virus a little bit more difficult, because it's got this latency period where you can be infectious but don't have any symptoms. Some people remain asymptomatic even longer, but about 98% of people will have developed symptoms by 11 and a half days. Again, that makes us, when you know that you've been exposed to a COVID-19 infected person, these are the timeframes when you consider, well, after 12 days, if I don't have symptoms, I'm unlikely to have gotten the virus. About 88% of the people will have fevers at some point during the illness. But in reality, only about 50% have fevers by the time they get sick enough and need to go to the hospital because of shortness of breath and lung problems. About almost 70% will have a dry cough, although occasionally it's a productive cough with sputum. About 4.5% will get a runny nose, as we call rhinorrhea, and about anywhere 4 to 15% will get some gastrointestinal symptoms such as nausea, abdominal pain, or diarrhea. It's also been noticed that virus can be shed in the urine and stool, although that's not the main way we infect other folks. So when we look at people that we know have gotten infected with this, the vast majority of people still develop mild symptoms. We call mild anywhere from just getting a runny nose or a mild cough to not requiring hospitalization. So that's a pretty broad spectrum of illness, but still the vast majority don't require hospitalization. We've been hearing about all the deaths, and we still think, wow, it's not like Ebola. And it's not even like the SARS epidemic from a little over a decade and a half ago. What's different is this is more contagious than even Ebola and SARS, and hence why it's spreading so quickly. About 14% will develop severe enough respiratory symptoms, and it's usually a viral pneumonia. Occasionally, they can get a secondary bacterial pneumonia with shortness of breath, usually as respiratory rates are greater than 30 per minute, and oxygen saturation less than 93%. That 93% is at sea level, and it's not uncommon for us to have saturations of 93% at Denver's elevation. So we usually take a threshold of about 90% at Denver. Certainly those with complex congenital heart disease, many folks do have saturations that are a little bit lower. Only about 5% develop what we call critical disease, which requires either the definition of high flow oxygen or mechanical intubation that's being put on a ventilator, or in rare cases, extracorporeal mechanical oxygenation, which we call ECMO. So what about the case fatality rate? Let's shed some light on what it really is and try to put it in perspective to other pandemics or severe outbreaks. So what we know estimated so far, and this is probably an overestimation, as I mentioned earlier, that we don't know the true number of people that are infected because minimally symptomatic people aren't getting tested. But about 1.4% patients will who develop symptoms will die. Compared to the known influenza infections, it's higher. In the rate of death with influenza is about 0.1%. So what we thought back in January, that this is maybe just a bad flu, it's not. It's worse than influenza, but part of that is because we do vaccinate influenza, those that are most vulnerable. Anyone with known heart disease should get a flu shot. So when influenza season comes upon us, mortality is lower because we're protected. When we look at SARS, which is a similar virus, it's in the coronavirus family, the mortality rate from that was 10%. So this mortality is not nearly as high as that previous coronavirus. So worldwide, though, as of today, the mortality rate is a little bit higher at about 5.6%. But again, that's because likely we don't have adequate testing. In China, they very rapidly tested the entire city practically of Hunan and got a much closer estimation. So the case fatality rate of those that are admitted was about 4%. In Italy, it was more than twice that. The reason, and all of us were asking why in in a country like Italy that has modern medicine, just like the United States and elsewhere in Europe, why was it twice as high as China? And what it is believed is that the Italian population, a quarter to a third of the population is above 60, and these people have the highest mortality. In France, it's very reported today, it's very similar to Italy, about 8%. In Iran, it was a little bit less at 7.5%. South Korea had the lowest percentage because they had a very aggressive public health approach to minimize infections, particularly the most vulnerable. In the United States, as of yesterday, we had a 2.9% mortality from those that were identified as being affected. And in Colorado, exactly the same as the United States, 2.9%. So as of last night in Colorado, there was 5,172 confirmed cases and 150 deaths. So what is the case fatality by age? And this is important, particularly for our Two Hearts community to think about. It's less than 1% for those that are less than 50 years of age. Yes, we've heard case fatalities of 19-year-olds without other medical comorbidities. It happens, but it is more rare. The mortality rate goes up with age, likely because as we get older, we get more medical problems, what we call comorbidities. And so those between 50 and 59, the mortality rate was about 1 to 3%. Those that are 60 to 69, the mortality went up to about 3.6%. From those that are 70 to 79, the mortality more than doubles to 8%. And it almost doubles again, those above 80, where about a 15% mortality above 80. Those that get sick enough and that need to be admitted to the intensive care unit, the mortality is about 50%. So when you hear about folks like the Prime Minister of Great Britain, who's now in the ICU, those are the numbers we have. When we look at, some of the researchers have been able to look at, well, who, aside from age, what are the risks based on medical conditions? And this is, I think, more pertinent to the Two Hearts community. So with no medical comorbidities, it was about 0.9%. With those with a cancer diagnosis in different stages of treatment, it was about 5.6%. With those with high blood pressure, it goes up by 6%. Although of all the patients that were infected with COVID, about 17% had hypertension. So we do think there's a link of having hypertension and being more prone to getting the infection. Those with chronic lung disease, which we call COPD, about 6.3%. Those with diabetes mellitus, hasn't been mentioned whether it's adult onset or juvenile type 1 diabetes, but about 7.3%. And those with known cardiovascular disease, about 10.5%. But keep in mind, we have no data to date on whether this is acquired heart failure, people with more advanced coronary disease and worsening heart function, or other causes. Now, Hunan, it was a city of more than 1 million people. So we expect, as we all know, congenital heart disease has a prevalence of about 1 in 100. So there must have been people with congenital heart disease that were infected, but we don't have any data on whether they did better, because many of them would be younger, or if they were in this 10%. So what about children? This is a study that I just saw come out today in the New England Journal. It looked at, in Wuhan, China, between the mid stages of their infection there, January 7th to 15th, 366 children were admitted to 3 hospitals there with respiratory infections. Like many places, most of these infections were not COVID, and about 6% were influenza A, about 5% influenza B, and only 6 children, or 1.6% of these, were COVID. And the table on the right shows what happens with these COVID-19 patients. Only 1 of the 6 required ICU stay, and in this case series, there was no mortality for kids. I want to emphasize that. Under those less than 16 years of age, there was no mortality identified. Now, there have been case reports of a few children dying. There was one that I had seen, there was an infant less than 30 days of age. And there were some other children with chronic medical conditions. But we are talking, in the reported literature, to my knowledge, less than 10, with about 1.2 million known infections in the world. So very, very, very small number. When we look locally at Children's Hospital Colorado, to date, we have only had 4 to 6 children admitted to that hospital with COVID. None of them have required ICU stay, and I know at least 2 discharges from it. To my knowledge, nobody in Colorado with congenital heart disease has been infected. We have not had any patients on the cardiology service at Children's, nor at university, although I'm not sure about Presbyterian St. Luke's. So here's some recent data, and this I wanted to talk about the importance of social distancing and how we've been able to do it. And I have a number of slides looking at different cities. This is a New York Times article also from today, looked at, in this column in the middle, the total number of deaths. So it's a decrease in rank order of number of deaths per city. And they looked at the total population of that city, and hence the number of deaths per population, or per 100,000. I'm sorry, not per population, per 100,000. And this is the effect of social distancing and how good those cities have been. So as we all know, we've been seeing for over 2 weeks now, New York is hit very, very hard. And their death toll, this is already outdated. I just saw a slide from Governor Cuomo, a talk this morning, that as of last night, the death toll in New York City is up to 5,489, and they had their highest death toll in any day yesterday at 731. But what I want to make a point is this has the highest number of infections per population. New Orleans does. And this is probably related to all the rapid transit and the close contact of New York City. In Denver, in Aurora and the greater metro Denver area, our rate is much lower. Our death rate was 67 as of yesterday, with only 2.3 per 100,000 people. So we've done much better. Looking at other cities throughout Colorado, Colorado Springs was a little bit higher than us, 3.9. Greeley was the highest, and it's no surprise, secondary to the number of large factories, particularly food processing plants in Greeley, that led to more close exposure, similar to the Detroit area where they had the large factories before they closed. Colorado Springs is a little bit more than Denver. And Fort Collins is probably one of the least, aside from Boulder, which is the least still. Interesting, I haven't seen Grand Junction, but they reported Montrose at 4.2. In Pueblo, they've been able to distance pretty well with 1.2. So let me talk briefly about treatments. That we have theories of treatments. The president has made it publicly known that the very old medications, chloroquine and hydroxychloroquine, which have been used for decades to treat malaria, and also in the last few decades has been used to treat some autoimmune disorders, such as rheumatoid arthritis or lupus, it's been shown to inhibit viral replication in a lab model. Early human case series, and these were very poorly done studies, they were just series of case reports, have shown a decrease in the amount of time that someone sheds the virus. Doesn't show that it made fewer deaths or fewer ICU admissions. Or if it was really the medications doing it, because they were really small studies. There are some side effects from these medications. It can cause bone marrow suppression, and important for our people with heart disease, it can cause some EKG changes, something we call prolongation of the QT interval on the EKG, which can increase the risk for a very dangerous rhythm called ventricular tachycardia. So to take this just to prevent infection, particularly in someone with a heart disease, is not a good idea. And in fact, university hospital pharmacies, to save the stockpile for the sickest patients in the hospital, has prevented providers from prescribing it to outpatients anymore. And I also carry a license in Wyoming, and the Department of Health and Human Services in Wyoming also warn providers that the amount of this prescription is going to be monitored carefully. There are some antiviral medications that is suggested to be effective, a combination of two antiviral medications called lopinavir and ritonavir, which are standard HIV medications. should be known that HIV is an RNA virus similar to this COVID. The initial case series did not show what we call a statistically significant outcome, but the numbers were low, and it did suggest a trend towards improvement. So I know at University Hospital, we are using that there for the patients, the 102 patients that are admitted there. Another antiviral medication called ribavirin may also be added with unclear effect. And there's what we call a monoclonal antibody. This is usually made through injected through horses, and we develop that antibody. It's an antibody specifically for a protein that our immune system makes called IL-6. And it's been found that those that get really sick that need the ICU, their immune system just goes crazy and releases incredibly high amounts of this IL-6, which really revs up our immune system. But in these patients that got sicker, it caused them to really damage their lungs. So there's been studies, and they've been started at University Hospital and many other hospitals throughout the country, looking at the efficacy of using this in a study form. So what are our concerns still in the front lines? Certainly for our first responders, anywhere up through the ICU doctors and the doctors in the hospital. Well, we still have inadequate testing. Despite knowing about this, our infrastructure was lagging on allowing tests to come online. And so this has really made it too late for us to allow tracking of exposures. And really, like what Korea had done in Singapore, is identifying cases and isolating all of their contacts as well as the cases. We have potential shortages of the medications I talked about to treat those that are truly ill. As I mentioned, Wyoming and UCH have implemented policies to try to maintain that stockpile. A huge concern remains inadequate personal protection equipment, or what we call PPE. Hospitals are using strategies now to reuse what we previously always discarded after each encounter. We would leave a patient's room in someone who was infected with another virus, and we would take the robes, gloves, and masks and throw them out to not get another patient sick. We can't do that anymore because we don't have enough masks. And in fact, both hospitals, University and Children's at least, are asking us to turn in our masks at the end of the day so that they can sterilize them using UV rays and kill any virus. And then we pick them up again so we have adequate masks. It should be noted that in Wuhan, China, there was 1,300 healthcare workers, from first responders to nurses and physicians and respiratory therapists, who became infected. And this is 3 times the general population. As I mentioned earlier, we may have inadequate hospital beds and ventilators in New York City. Really, that occurred and hit them hard. Talking to my ACHD colleague who directs NYU's program, he clearly was shocked, and the whole system was really trying to recover, or still trying to recover. This is an old slide. As I meant last week, we had seen what we call a nonlinear increase in the number of COVID patients, meaning it became exponential day to day, and that looks like it's plateaued in the last 3 days, but that remains to be seen if that's going to continue. And keep in mind, even though we think, well, hospitals are going to financially do okay during this because they're taking care of the sick patients, that's actually not the case. Hospitals and the divisions of our hospitals are suffering financially just like all the other businesses throughout the region, because we're not seeing patients in clinic anymore. We're not doing elective procedures that we think are needed for our patients. And so financially, we're struggling to figure out how we're going to pay our nurses who aren't in the hospitals, our echo techs who are not echoing patients, and so forth. So everybody's struggling with this. If you're wondering about how you can help, there's some websites here that give information, such as Children's Colorado Coronavirus. And what is still important is if you're not infected with, if you know you haven't been infected and you're healthy, blood donations are critical because the blood drives have gone down, and we are still needing to do surgeries at Children's and University Hospital on urgent heart patients, particularly those babies that are born with critical congenital heart defects. And we are still doing heart transplants. I know we have at least 2 or 3 patients that are on either ECMO or what we call ventricular assist device, waiting for a heart transplant. And so blood donations are important. And I would look at bond fees or Children's if you're healthy and able to give blood. So sorry for going on a lot, but I'll unshare my slides and open it up for questions.
Hey, Dr. K, I've got a question in regards to that. So with, me with doing international travel, basically because I've been to Kenya, they say I can't donate for a year. Are they still keeping those same restrictions with blood donations?
Yeah, that's a great question. And yes, that's the case because particularly the malaria, that's one of the biggest infections, but other potential infections that we don't know about. And when we're given these transfusions to the sickest of the sick, potentially immunocompromised for heart transplant patients, we can't afford to allow them to get sick from donated blood pool. So yeah, that's, to my knowledge, those restrictions are still in place.
Other questions? I'll ask some questions. So what if they think their child, their teen, or they have it? Like, what should they be doing if they think their child with CHD has it? Teen.
Sure. If you don't already have, I strongly encourage you to at least order online. My family did this, a pulse oximeter. And just the backlog on obtaining a pulse oximeter, an adult pulse oximeter through Amazon is like a month, but we ordered a pediatric one because a pediatric one will work on all of us, and we got it within a week. So having a pulse oximeter, if you know somebody who has a pulse oximeter, I think would be very important, because if you think they have the infection, the time when you need to come to the hospital to be evaluated is when your oxygen levels drop, and that when you need supplemental oxygen. Now, this can be, I know many folks in our that are on this conference call have a loved one with, let's say, a single ventricle Fontan, and many of their saturations may be below 90 as well. So knowing what their baseline saturation is important. And so symptoms, the combination of symptoms of shortness of breath and a drop in their pulse ox is a reason to come and be evaluated.
Dr. K, when you say shortness of breath, do you mean like they're extra winded, like they just ran a mile, or is it they literally can't catch their breath? What would be the actual indication?
The early signs would be what we call dyspnea on exertion, or shortness of breath with activity, where all of a sudden you can't do the same amount that you could do a week ago. The more severe signs that may require hospitalization is shortness of breath at rest. Some of the adults that were requiring hospitalization, they had normal saturations, and their saturations are dropping in the 80s and the 70s because of severe lung problems. Another thing that I want to talk, that I didn't mention in the talk, is this is primarily a lung problem. There is concern that it could infect the heart or affect the heart. By infect, I mean there's receptors on the heart muscle for this specific virus. It's called ACE3 or ACE2 receptors, which we all have. And those receptors are in the lung, and that's how the virus is getting into the lung tissue, but it's also in the heart tissue. We know from those adults that got sick, that died, the 50% that died, about 20% of them had injury to the heart during the infection. Now, we see that in patients that come to the ICU without COVID-19 when they develop a severe inflammatory response and are just really ill, that the heart can get injured and it not being permanent. So to date, we don't have a lot of evidence that it causes worsening of the heart function after infection. In fact, we have very little evidence of that. That's been looked at.
So when it comes to, traveling, obviously with Peyton being actually still in Kenya, what type of precautions will she need to take when it does come time for her to actually be able to come back to the U.S.?
My first question is, when was the plans for her to return?
Original plan was January of 2021.
We don't know. We in the United States need to learn a lot from China. As China just released the restriction on Hunan, the city that was affected today. So people in Hunan are now able to travel outside the city. Italy and New York City are making plans, and we think the United States is going to try to do this outside of New York, is to test people. So first on who's developed antibodies, meaning they've been infected, but they developed antibodies and are hopefully immune to the virus. And they're going to start looking at who's immune and allowing them to go back to work and travel. You can imagine areas like airports where you have huge amounts of people congregating near each other and it's hard to wash your hands and stuff. It has been shown to be an area where a high number of people are getting infected. So staying away from airports until this really dies down, I think is going to be really important. And time frame, we don't know. It remains to be seen. We're going to have to learn a lot over the next 2 months.
Dr. K, you know that Maddie works at the VA, and so is there any other additional concerns that should she be taking her shoes off in the garage? Carrie and I are at home all day, so we don't want to cross-contaminate things. And Chris is, of course, working still in different facilities. He's going into, he's delivering overnight. So he's touching door handles and all that kind of thing. Any other precautions she should be taking at work? Or she's in patient transport, so I don't know that there is much different she can do, because it seems like they have enough PPE, but just want to have her thinking more like a 30-year-old than a 20-year-old sometimes. So,
well, we don't have the best answer, but what we are doing, what nurses, providers support at University Hospital and at Children's, is if they can get scrubs, then it's recommended that people wear the scrubs at the hospital and then leave them to be cleaned at the hospital. I don't know what the VA's policy is on scrubs. University Hospital doesn't allow all employees to have scrubs. So people are then bringing their own scrubs in if they had them, or the uniforms. If you have to bring your clothes home, it is recommended that you change as soon as you get there and take a shower, and take those clothes immediately and get them washed to minimize contamination, and constantly wash your hands and clean surfaces. And those that are coming in and out of hospitals or sites where this is higher in concentration, it's critical to wipe down surfaces in your house, clean your hands repeatedly to decrease the chance.
And I had one other, yeah, no, it does. It does. It's probably just expanding on things that we've already thought about, but I just need to get her on the ball for that. I had one other question that I've been seeing as a possibility for letting folks know that they might have contracted it. Is there any truth to the fact that maybe a Fitbit might have a dip or a change in your heart rate to be able to tell you that you've got something going on?
Unlikely.
Okay.
Possible, but unlikely. Because the Fitbit is better for identifying heart rhythm problems. And while the sickest of the sick may get heart rhythm problems, we've not seen that in too many patients with the more mild infections. So unlikely the Fitbit would be significant value.
So it sounds like generally our kids' age range, teenagers are not very likely to contract it. And if they were, they might be a little more elevated with their heart conditions, but the chance of them getting it is very low.
It's hard for us to know chance of them getting it.
Okay.
But that is correct in saying if they get it, the chances that they're going to get more severe illness is very low.
Okay.
Now, there's still subpopulations that we in congenital heart disease get a little bit more nervous about. We just don't have data to say if our concerns are true. These are people who got heart transplants and are immunosuppressed. Because they may not know that they have the infection until it's more advanced, because the immune system, the transplant patients that is, and those with our Fontan. We don't know that the Fontan patients are more likely to get sicker and in the ICU than anybody else. But if they get sicker and have to be in the ICU, the ability to treat them with mechanical ventilation is a bit higher risk. So those are the two populations within congenital heart disease that we're more concerned if they get infected. Okay. But it's been reassuring. We've not heard of very many instances. In New York City, for example, I've heard from my colleagues at Columbia that a couple of their adults with Fontans had been infected, and one was home, one was in the hospital, not in the ICU. So our early information is promising that our congenital heart patients aren't at particularly higher risk, but we just don't know.
Okay, that's what I've been trying to read as a parent of how elevated is my daughter, what's her risk level compared to everyone else? Should I be even more cautious with her because she's a Fontan kiddo? Trying to figure out, they're saying people who are immune suppressed and people with underlying conditions, yet she's also a healthy teenager. So,
yeah.
It's that mix of trying to figure out where she is in all of that.
Yeah, we just don't know yet. I mean, the younger age, meaning if she's doing well with the congenital heart disease, any of the people, um, we don't know. Theories is that kids are exposed to so many viruses throughout their daily life that their immune system is healthier and more active. So we think that's why kids are being spared, because they have such a vibrant immune system that prevents the virus from really settling in the lungs compared to adults. That's just a theory. But it's that balance of the immune system that some adults' immune system go into overdrive and really start destroying other organs. That why some get sick. So yeah, we're hopeful. And a call out to everybody there. If any one of your children or you with congenital heart disease get COVID-19, like you've been tested and you know you have it, please let your providers know. Specifically for our adult congenital heart disease population, we're taking part in an international study, which is going to be tracking all of our adults with congenital heart disease who contract COVID, and will give us hopefully more information on whether or not this is going to, how they do. Are they at any higher risk, or are they at equal risk? So us tracking this is very important.
Dr.
However, Jamie and Heather, you're not allowed to get COVID, so that takes you off the table. You're not allowed to get sick.
Okay. I swear I had it, but it was probably just a really bad flu. But I was also advised to not go to the emergency room, to stay away from any medical facility, because of how much crud is surrounding the place. So where would you suggest someone who has CHD and they suspect they have it, where can they safely get tested without being exposed to anything else or to exposing anyone else?
Great question. And this is a moving target that's changing every other day. So get in touch with your physician, either your primary care physician or your congenital heart specialist, your cardiologist. We still do not have adequate testing in Colorado to test the relatively healthy outpatients, meaning you're not sick enough to require admission to the hospital. So there's just not enough testing capability to do that. So if you're sick enough that you think you may need to come into the hospital, that's the time. But we may get more testing by the end of this week or next week. And so if you're coming down with something, then we could direct you to get tested. The turnaround time, I know some of the adolescents, parents in the group have been tested. And back then it was 3 days, 5 days. The turnaround test at both University and Children's Hospital is now a day for understanding it. We don't yet have that 15-minute turnaround time. Merck, who makes that test, is just trying to increase supply to get out to different communities. But it's still a day turnaround time, and we're limited on how many we can run per day. So they're still trying to reserve healthcare providers who may have symptoms, testing them so they don't infect other people, or patients who are admitted to the hospital. As of today, those are the ones that are still getting priority for testing.
How susceptible are heart transplant patients?
Can you repeat the question? Your audio broke up a little bit in the beginning.
How susceptible are heart transplant patients? to picking this up?
It's a good question. We don't know yet. We don't have evidence that they're more susceptible of getting the infection than other folks. But we do worry because of their immunosuppression, that if they got it, they could get much sicker. Two ways they could get sicker. One is the virus takes hold and it causes the lung damage that we're seeing with this virus. A second way is any infection a heart transplant patient gets, it revs up their immune system, and that even though the virus may get controlled, their immune system being revved up could cause rejection. So we certainly worry more about our solid organ transplants, particularly heart transplant patients, getting the infection and having a significant problem. But we don't have evidence that they're more prone to the infection.
I have two questions. I feel like there's like some different, I don't know, I've heard two things. If you have the virus and you get better, can you get it again? Oh, you're muted still.
Sorry, I'm getting phone calls and I'm just gonna text some of these folks back. We think it's gonna cause, what our knowledge about tolerance or immunity to this virus is based on previous coronavirus infections. So the common coronavirus that's been in the community causes cold symptoms, or SARS, or this other, what's called Middle Eastern Respiratory Syndrome, MERS, which was one of the last worrisome viruses, which is coronavirus. It looked like the immunity for those people waned over about 2 years. So we think you're going to be immune for anywhere from 6 months to 24 months. And similar to influenza, you need an annual flu shot. We think that's going to be the case with COVID, but we just don't know yet.
And then obviously it seems like this is the most important time to keep like our lungs healthy and all that stuff, but is working out, like it was going for runs and stuff, you think still safe, or you don't think patients should be doing that?
It's a good question. Exercise is important for all of us, both mentally and physically, but it's important that we follow the regional restrictions. I've seen lots of runners out there without masks, and technically that's illegal. We are supposed to wear masks when we're out in public, and it's hard to run when you're wearing a mask. But it's also, if you're asymptomatic and you're running and you don't have a mask, you're going to be expelling, aerosolizing farther distances because you're breathing heavier. And so as you're passing people, in an example in Stapleton, Westerly Creek, it's impossible now to social distance yourself because there are so many people out there right now. And so as runners, you're going to be exposing people to the virus if you're in that early phase of 5 days to a week infected and not covering up. So exercising is critical, but I do recommend trying to exercise with a mask to keep other people safe.
I also, my sister-in-law works in the ER in Iowa, and they are recommending high doses of vitamin C as a prevention, or is there any truth to that?
Not that we know of.
Okay.
There is some evidence that vitamin C can boost your immune system, but it hasn't really panned out as being really making a difference in other things such as influenza. So against this, there's no data. It's not harmful. Vitamin C is a water-soluble vitamin. So as long as your kidneys work well, you're not going to overdose on vitamin C. and maybe it's helpful. It's unlikely to be harmful.
Okay.
Any last questions?
Bueller?
Well, thank you, Dr. K. That was really helpful.
That was my pleasure.
Yeah, I really appreciate it.
Thank you.
Yep.
Everybody stay safe. And if you have any appointments scheduled in the next month or two, expect to get a call from us and ask if we can do this telehealth, very similar to this conference call.
That's good. Okay, well, thank you so much, Dr. K. Thank you.
Yeah,
Thank you.
thank you.
You.
Thank you.
Very much appreciate it.
No problem.
Does everyone feel better, more informed?
Yeah, I feel a little bit more scared, but sure.
Sorry. If you have any questions that you thought of afterwards, by all means, send them to Jamie and Heather, and they can forward them to me, and I can answer.
Yeah, no, this is very helpful, Dr. K. I work for a company who does your hospital security. So
Okay.
get the questions nationwide. So this was very helpful.
Okay.
Thank you.
Thanks.
Thank you.
Okay.
Thank you.
Thank you.
Bye.
Right, everyone. And email us if you have any questions, and we will get the answers to you via this guy, Dr. K, over there.
Mhm.
Right.
Okay?
Thank you.
All right, everyone. Take care.
Bye.
Wash your hands. Bye.